Hello, viewers. Today, I'm sharing a case of non-union tibia. Patient sustained injury from paragliding accident. This is my contact details. This is the number of things which we do treat. Disclaimer: this is how patient sustained an injury while he was doing paragliding at Kalimpong, West Bengal, and he fell from 1,000 feet height, and the coach with him died on the spot, and he sustained multiple injuries. As one can see here, that there was some failure with the device. These are news coverage of this. The news coverage of that. So this 32-year-old male patient had history of fall from 1,000 feet height. This mishap happened while paragliding at Kalimpong, West Bengal. Coach died on the spot. My patient, Gaurav Chaudhary, fortunately survived with multiple injury. He had grade 3B tibia fracture, closed fracture of shaft of humerus, and chest and head injury. Index surgery was done in the form of external fixator in tibia and humerus interlock nail at West Bengal. After 3 weeks, he returned to his hometown at Kanpur and got admitted at local hospital, where first cross leg was done at 3 weeks. At 8 weeks, as cross leg flap was rejected, the free flap from left forearm was done. At 3 months, skin graft was done. At 4 months, external fixator removed and fiber cast applied, which was kept for a period of 6 months. 10 month post injury, he shifted to Patna for further treatment. Initially, someone had applied LRS. After 1 month, LRS was removed and ILIZAROV frame was applied. Patient had around 3 centimeter bone gap plus some shortening. At 25 months, patient had been in frame for a period of 14 months. Frame was removed, fibercast was applied for 3 months, and followed by PTP brace for 8 months. So overall, in a span of 3 years, patient had a non-union. He was not walking without support. Multiple consultation and hope for limb salvage, and many of surgeon advised him below knee amputation. He was unable to walk unaided. He required help of walker. He had some shortening, persistent non-union, foot drop, equinus deformity, and due to multiple surgery, he had drained all savings. Had been given in writing by one of head of unit at teaching institute at Metro Hospital that limb is not salvageable and an amputation is only option. Furthermore, patient was told that even if fracture unites, he will not be able to walk again. He had profound disturbed psychology. He was inclined for amputation. I couldn't convince him for salvage, but one of my operated patient, convinced him for salvage. This is his 3 week post-injury clinical picture. One can see that there's bone exposed, external fixator in situ, multiple drill hole are done, muscles and tendons are exposed. Someone had applied frame, and this is 5 month post ILIZAROV. One can see that there is a residual translation and angulation at docking side. A closer view of docking side, one can appreciate that there is some residual angulation and translation. So overall surface area in contact is minimal, and that may be the reason for persistent non-union. This is 10 month post ELISA, which was applied at Patna, and at 14 month frame was removed at Patna, and patient was given fiber cast, which was kept for 3 months. Then cast was removed and PTP brace was applied, which was kept for 8 months. So this his gait video post frame removal, post brace cast removal with brace. So he was walking with brace with walker, and one can see that the moral is not so good. One can appreciate from his face. This is what he was advised about below knee amputation given in writing. At 3 years, he presented to me with this gait. He had equinus, non-union, and he was walking with walker only. He presented to me at 3 years, and this is his clinical picture. Closer look, one can appreciate that there is a scar of on opposite limb of free cross leg flap and an forearm of free flap, multiple scars on limb and healed scar over dorsum of foot also. Uh, Clinical picture from front, back, and side. This is his radiological picture at the time of presentation to me. As there is a gap nonlinear in fibula also, it is very difficult to appreciate shortening from single limb radiograph. So in such cases, clinical measurement of limb length and scanogram helps to understand the amount of shortening. As one can see from here that the operated limb is little bit shorter as compared to normal limb. The shortening was around 2 centimeter. Uh, Strategy for treating this patient would be resect avascular bone, refashion bone ends, and apply 4-ring concept and foot frame to address equinus. Whether I would do a single corticotomy or dual corticotomy would depend on the size of gap. These are tentative area of resection at proximal and distal fragment, tentative ring configuration, and corticotomy would be done between first and second ring or second and third ring or at both places. Post debridement, there was around 6 centimeter bone gap and patient had 2 centimeter shortening. So overall, the size of defect was 8 centimeter. Since patient had spent significant time before coming to me and had undergone significant morbidity post-injury, suffered for 3 years, I prefer to do dual corticotomy to reduce time in frame. This is how a tendon trifocal osteosis is done to reduce time in frame. Closer look at proximal fragment, a proximal and proximal metaphyseal, and second one a diaphyseal corticotomy, both done with freehand technique. Closer view of distal frame and equinus assembly applied to correct equinus. Patient reached stage of docking at 5 weeks and he came for follow-up after 5 weeks. Another follow-up at 4.5 month, 5.5 month, and 7.5 month. At 7.5 month, fourth follow-up post-discharge, clinical testing was done. Rods at fracture sites were removed. Fracture was united. Patient was not having any pain. There was no abnormal movement at fracture site. He was able to stand and walk without support. As one can appreciate in this video, that patient is walking without any support and there is no connection at fracture site. At this stage also one can remove frame and protect it in cast or brace, but I counsel patient to keep frame for further 2 months to ensure solid union and regenerate consolidation. I advise him to dynamize the frame. The nuts at corticotomy and docking site were loosened. Instead of 4 rods, 3 rods, 3 connecting rods were applied at proximal and middle corticotomy site and docking site. And patient was advised to remove sequentially half pin at home so that when he reached to me at 9.5 month, he had all wire frame, good regenerate consolidation, and good union at docking site. Clinical picture standing without connection at corticotomy and docking site. Radiological picture without connection at corticotomy and docking site. Again, clinical testing done for regenerate site and fracture site. Patient walking unaided without any connection at corticotomy site and docking site. So at fifth follow-up post-discharge at 9.5 month, frame was removed. Overall healing index was 36.4 days per centimeter. Fracture united, regenerate consolidation, consolidated, equinus corrected, and there is no limit discrepancy. And overall results are quite good and quite comparable to a normal side. This clinical picture post frame removal, gait post frame removal, walking unaided, and eventually over a period of time with physiotherapy, his gait will further improve and he will be able to walk little better and faster. So ultimately, fracture that had not united in 36 months, united in 9.5 months. limb salvage, patient walking unaided. He had lost hope for walking unaided in his whole life. Return to pre-injury occupation possible post-salvage. Bone grafting was not done in this case. There was no shortening. There is no deformity. So learning points are: pay due attention to ring placement for better radiological assessment. Avoid translation and angulation at docking site. Dynamize frame. Always do clinical testing to evaluate union clinically. Remove frame once assured healing is there.